Good evening. Thank you to the organizing committee for this invitation. When I asked Mr. Google what is the meaning of pearl, he says these are small bits of clinically relevant information based on experience and also on observation. So here are bits and pieces of my humble experiences and observations, and must know, in my opinion, for some derm surgery procedures. Is it cannula or needle for filler injection? I cannot but overemphasize the importance of knowing our facial anatomy. Blindness is a rare complication, yet it is on the back of the injector's mind all the time when doing fillers. What are the danger zones? We may know our anatomy well. Unfortunately, abnormal or aberrant vessels may be present or located where they should not be. So accidents and adversities can happen even in the hands of a well-qualified and experienced injector. It takes as little as 0.4 to 1.2 ml to occlude a vessel. What are the tips to decrease risk of vascular occlusion? Always aspirate, though it is not 100% guarantee, especially for viscous materials. Don't do bolus, especially in danger zones. Inject very slowly. Inject gently and avoid pressure in the plunger. Do retrograde or fanning technique if possible. Keep cannula or the needle moving. Never inject in a bleeding hole. Assess mobility of cannula and place it in an area of least resistance. Position cannula perpendicular to the artery. Compress blood vessel leading to the eye when injecting in that area, or in the case of the nose, pinch the nose. Stability in injection is precision. Variables to be considered are the angle, the depth, the entry, and the volume. Watch out for pain or blanching, which are usually immediate, within seconds, though there are reports up to 24 to 48 hours post-injection. Monitor for small rays in skin. If you see none, then you withdraw to be safe. This brings us to the question of when to use cannula or needle. Which is safer, cannulas or needle? Briefly, I like to mention a cohort study done in August 2018 to August 2019, published in JAMA Dermatology in 2021 by Murad et al., participated in by 370 derms with average of 23 years in practice, with total of 1.7 million mils of filler injected. Findings show that occlusion risk per syringe decreases after first few years of doctor's practice and lower among those who frequently inject filler. In fact, if injector has more than 5 years of practice, there is 70.7% lower odds. Conclusion: with needle, 1 vascular occlusion in 6,410 injections. With cannula, 1 in 48,882 injections. Result shows 85% with low long-term sequelae and resolve without scar or injury. Results show 6 times more vascular occlusion with the needle. So are we going to scrap needle totally as an option? This study, however, noted incidence of degree of severity to be more with the use of cannula, probably due to bigger volume used. Many injectors will prefer several cases of mild effects rather than one case of severe sequelae, like visual disturbances to blindness. So it is frequency versus severity. What will you choose? There are many variables or factors to consider: the depth of injection, the anatomical site, volume to be used, bore and length of injection instrument, and the operator experience and technique. It is actually a matter of the injector's preference. My take on this is, for areas that have to be injected directly to the bone, my preference is needle so I can access the bone better. Like for example, the cheekbones, the chin, the temple, gonial angle, and the jowl. With cannula, it will be more difficult for me to go deep to the bone without causing pain and bagginess due to thin skin. Other areas, depending on variables mentioned, I will use a cannula. My go-to for cannula is TSK, gauge 22, which is thick enough to be safer than gauge 25. The TSK brand is dome-shaped, it's narrower, it glides more easily, it is more rigid, thus giving more control and more feel of the area. Botulinum toxin injection, few tips here and there. Treatment is a journey. It is not a single treatment with a destination. This is especially true for new patients. Always leave a room for adding doses or touch-ups in the next visit. Depth. These are the muscles where you have to go deep. The corrugator and the PROCERUS muscle. If you inject superficially here, the toxin will go to the frontalis muscle, which connects to the orbital rim, so you can have possibly eyebrow ptosis. It is worth mentioning here that the tail of the corrugator muscle is located superficially, so you have to inject superficial. Otherwise, if you go deep, it will diffuse to the levator palpebra superioris and cause eyelid ptosis. The masseter, you have to go deep. Otherwise, you will hit the risorius muscle, which is superficially connected to the masseter. This will result in shortening of the mouth or asymmetrical smile because risorius is responsible for pulling the corner of the mouth when we smile. The DAO, or depressor anguli oris, is the muscle that pulls the angle of the mouth inferolaterally in expressing feelings of sadness or anger. Mentalis muscle, you have to go deep so it will not diffuse to the DLI or the depressor labis inferioris, causing asymmetrical smile. DLI is responsible for moving the lower lip downward and laterally to expose the bottom teeth during smiling. For the platysma, you have to go deep. For the rest of the face, inject superficially. If the patient just wants treatment of the forehead lines without treating the glabella, however, upon assessment, you see that there is eyebrow ptosis already. Explain to the patient that there could be aggravation of the brow ptosis because of the additional downward effect if you just inject the forehead. Do not overtreat the crow's feet in the orbicularis oculi area, so you still have the Duchenne smile. What is a Duchenne smile? Duchenne smile is the smile that reaches your eyes, making the corners wrinkle up with crow's feet. It is a genuine, often involuntary expression of happiness by contracting the zygomaticus major and the orbicularis oculi. When you inject the glabella, compress the orbit all the time to prevent the accidental diffusion or migration of botulinum toxin to the levator palpebra superioris, which will cause the eyelid ptosis that we all dread. Meet AGNES for syringoma. Disclaimer, I am not an endorser of this machine. We just happen to have one in the clinic. AGNES is an innovative device from Korea. It uses radiofrequency waves to target problem areas under eye bags, eye wrinkles, double chin, syringoma, and acne. My experience is more with syringoma cases. I offer these to patients who are looking for a better alternative for syringomas other than electrodesiccation and curettage. As we all know, this has a long downtime of 2 to 3 weeks depending on the depth of EDC done, with all the scabs and hyperpigmentation sequelae. While on the other hand, AGNES uses a microinsulated needle which delivers radiofrequency energy to deeper layer of the skin without causing burning. No scab formation with little to no downtime for healing. This machine targets the bump by breaking down abnormal tissue and stimulate production of new collagen. Bumps eventually smooth out and disappear after a few sessions. The improvement is steady over a few months with subsequent visits and with high patient satisfaction. Beauty comes from within jars, tubes, and bottles. Do not forget to offer skincare product options to our patients which can improve patient satisfaction and enhance results of treatments done. I will end my lecture by mentioning again the observation of JAMA 2021 study by Alan Murad et al. That occlusion risk per filler syringe decreased after the first few years of doctor's practice. Doing derm procedures is a journey. There is always a learning curve for these procedures. Just like the wine, it gets better with age. Years of experience and practice give us the confidence to perform better. The most difficult step is the first. It comes with doubts, fears, and uncertainties. But if you take it, it's the first step in your master journey. Thank you for listening. Again, good evening.